Start letting everybody in.
Okay.
Yeah, you guys are already on it. Wait just 1 or 2 minutes so that we give a chance to our participants to log in, but we'll be starting soon. Thank you for calling in today. Okay, I think we'll get started. So welcome everyone to our new series, Oxygen Therapy and Critical Care, the case-based series. Today, we are happy to start the program off with session 1, Considerations for Triage. Our director for this course is Dr. Pauline R. Banguti. And we are also pleased to have with him several co-panelists who will be helping the session along, Dr. Libere, Dr. Ingabiri, Dr. Muvkihi, and Dr. Uimana. So thank you so much for joining today. We do have a couple housekeeping items before we start. So just to begin with, our programming is based on a foundation of love and respect. So please respond kindly rather than react if you disagree with something that is said. It is everyone's responsibility to keep this webinar a safe space. We will be using the chat function for question and answer. The button to use the chat is at the bottom of your screen. So please send all questions through the chat box and feel free to introduce yourself. If you have comments or insights you'd like to share, definitely use the chat box for those as well. If you can, please turn on your video, position your webcam effectively to show your face if alone, or to capture the whole group. If you have any IT issues, send us a message through the chat to Echo IT. And then finally, this session is being recorded, and so your attendance is consented to be recorded. We will be circulating the recordings after the session as well in case you would like to review the content. And then before I pass it on, just in general, please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing when you can. Okay, so with that, I will pass it on to Dr. Banguti.
Thank you very much, Alana, and thanks to all for joining us for this very first session of the year. As you know, it is a 12-session course where it starts in January until December, and we've invited all of you to register for all 12 sessions. At the end, you will get certificate. So we'll give more explanation on our website, our WhatsApp group. We encourage you to be really to avail your time and follow all the sessions. For today, the methodology will be simple. We will start by a main presentation for 30 minutes where we will be sharing all of us together. Then after 30 minutes, when we finish the first part, we will break out 3 stations, so that you will find yourself in one station where you will go in deep knowledge of what you've learned. And after every 15 minutes, you'll be rotating in another session. So the 3 sessions are the breakdown of what we'll be discussing soon. So by at the end, we'll come back again in one session, in one room to wrap up and close the session. The whole, from the beginning to the end, we can spend 1 hour and a half. So be patient and stay tuned with us up to the end. Next slide, please. So today we are discussing about triage. Next. So as you can see, we are no, go back a little bit. So we have some practice change objectives. So at the end, by the end of the whole session of today, we're expecting some changes in healthcare providers to be follow recommendation for PPE guideline, personal preventive from exposure. We are expecting you to get some knowledge and to start practicing the donning and the doffing. We are also expecting you to all patients with potentially contagious infections are isolated early by triage, screening for and method for the COVID coronavirus should be put in place. Also, you should be able to recognize, to diagnose hypoxemia and start treating by giving appropriate treatment for hypoxemia. And at the end, how to use the appropriate device for oxygenotherapy. So from this, I pass the baton to the next team to continue. Libere.
Dr. Libere, I think it's a little bit difficult to hear you. Are you using headphones, or can maybe try taking them out? It's very faint. It's a little bit better, still quite difficult to hear you.
I will try my best to speak loudly. Is it fine now?
Can you speak loudly?
Yes, I'm speaking loudly. Is it fine? Okay. The question is to know how will you evaluate these patients at emergency room. Next slide, please. As you know, when we have a patient at the first time, we need to go. Yes. As a culture, I know all of us, we are nurses, we are doctors, so we have a good culture of following some steps for hypoxemia. We can have our patients perfectly. So, we need to introduce ourselves to our patients, we need to gain a consent, we need to know when a patient is present, is at the hospital.
Dr. Libere, it's still quite difficult to hear you. A couple of people have mentioned that in the chat. If you're using headphones, could you try to remove them and just speak directly into the computer?
Not work.
Maybe that might help.
Is it fine now?
Can you just put the mic
Libere.
to your mouth? I think
Excuse
you're
me.
using the headphone and the headphone is too far. The mic. Can you just put nearby to your mouth if it is possible?
Libere, kuramo kuteri.
It will not work.
Kuramo kuteri.
It will not work. No.
Dr. Liberta, if you're using earphones, could you please try removing them and maybe we can just try it out once?
Is it fine now?
If your microphone has a microphone enabled to it, if you could just hold it closer while you're speaking, maybe that will help, or maybe you can just remove the earphones and maybe that will work.
Is it fine now? Hello?
It's still quite quiet, unfortunately.
I'm sorry. Let me try to speak loudly. Can you hear me now? Can you hear me? Can you hear
Very,
me?
very quietly.
We can hear you, doctor, but very lightly, like your voice is.
I will try my best. I don't have any other choice. So I was saying that when you have a person, you need to take our patients by uh, so we start by introducing ourselves, gain their consent for helping our patients. Then we ask why the patient is present at the hospital. Then we ask about the patient's past medical history, drug history, and so on. Next slide, please. Next. So we go a systematic review of all both systems. Then we try to summarize the patient's history so that we make sure that what the patient is saying does is what we have recorded. We ask if the patient has had information, then we send the patient. Next slide, please. Next slide. Okay. So as a practitioner, you decide to perform a history and exam of this person. When interviewing the patient further about the history of this disease and illness, you discover he has a 4-day history of fatigue, weakness, and dry cough. His wife is a nurse at the hospital and tested positive for COVID 3 days ago. His wife has caused a and had the patient take oxygen saturation. The reading was 89%. So PPE to help this patient. The next floor is for Dr. Fabier. Thank you.
Dr. Libreta, we are getting feedback from the participants that they cannot hear you that well. If you could just try removing your earphones and disconnect it from the system, that might work.
What we can do now, are you hearing me?
Yes, Dr.
To try to catch up a little bit on what Libere was saying. Alana, can you go back with the slide a little bit? So the question was, you have such patient with chills and coughing. So the question was, how do you assess this patient? So Dr. Libere was discussing about how to assess a patient with those symptoms. So the main message is always try to get a consent from the patient before assessing a patient. And you should do a proper history. You first present yourself to the patient, get a proper history, and you follow the 11 steps for a proper history and assessment. So all those points will be discussed during the breakout session, and I'm sure we will catch up. So the next question was, next slide. Okay, yeah. So it is, should you beware of PPE when assessing this patient? That's where Francois is coming in to discuss how to wear PPE. Meanwhile, we request Alana to show us a video on how to put on, how to don, and how to doff as Francois is preparing himself.
Okay.
How to safely put on personal protective equipment, or more commonly called PPE. We will demonstrate one way to appropriately put on or don PPE. More than one donning method may be acceptable to your facility. It's important that you receive training, demonstrate competency, and practice your healthcare facility's donning procedure. First, identify and gather the proper PPE to don, including an appropriately fitted isolation gown, a NIOSH-approved N95 filtering facepiece respirator or higher level respiratory protection, or if a respirator is not available, a face mask, a face shield or goggles, and a pair of disposable patient examination gloves. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Put on the isolation gown. Tie all ties or snap all snaps. You may need assistance from another healthcare provider. Put on the N95 respirator. When using a respirator with a nose piece, fit it to your nose using both hands. Do not bend or tent the respirator. Extend the respirator under your chin, protecting both your mouth and nose. Pull the top strap over your head, placing it on the crown. Then pull the bottom strap over your head, placing it at the base of your neck. Lastly, perform a user seal check. Do this by using your hands to cover the surface of the respirator and gently exhale, checking that the facepiece bulges slightly. Then, while keeping your hands over the respirator, take in a quick, deep breath, checking that the facepiece collapses slightly. If air escapes through the edges, readjust the fit of your respirator and perform another user seal check. Do this each time you put the respirator on. If a respirator is not available, put on a face mask. Extend the face mask under your chin, protecting both your mouth and nose. If the mask has loops, hook them around your ears. If it has ties, secure them at the base of your neck and crown of your head. Next, put on a face shield or goggles. Lastly, put on your gloves. Pull the gloves down so that they cover the wrist of the gown. You are now ready to enter the patient's room.
So you enter the patient's room. Do you hear me? The audience, do you hear me?
Yes, we hear
please.
you well. Thank you.
Okay. After you done in, you enter to the patient room, and then you do your practice. You treat your patients, and then you come out with doffing. Can we have that doffing video? Marina?
How to safely take off personal protective equipment, more commonly called PPE. We will demonstrate one way to appropriately take off or doff PPE. More than one doffing method may be acceptable to your facility. It's important that you receive training, demonstrate competency in removing your PPE without contaminating yourself, and practice your healthcare facility's doffing procedure. Remove and discard your gloves. Gloves can be removed using more than one technique. For the glove and technique, pinch the outside of the glove near the wrist. Peel downwards, pulling the glove inside out. With your ungloved hand, slide your finger under the wrist of your remaining glove. Again, peel downwards, turning the glove inside out. Discard the gloves. For the beaking method, pinch the outside of the glove near the wrist. Using your finger, pull the glove inside out and over the fingers and thumb to form a beak. With the beaked hand, pinch the opposite glove at the wrist and pull downwards, turning the glove inside out. With the ungloved hand, pull the beaked glove off, touching only the inside of the glove. Next, remove your gown. Untie all ties or unsnap all snaps. Some gown ties can be broken rather than untied. In that instance, break the ties gently, avoiding a forceful movement. Reach up to the shoulders and carefully pull or roll the gown down and away from the body. Dispose of the used gown. You may now exit the patient's room.
So as the healthcare provider who was in the room of the patients who need the isolation, how did you triage the patient when he was in after you done in? I'm asking the question to the participants. How do you do triage when you arrive in the room of patients? The audience? To the audience, we'll discuss more about PPE donning and doffing in the breakout sessions. So to this time, I'm asking the question about triage of patients when after you don in, and then you go to the patients, how do you do triage? No one has an answer? So we will see in the breakout sessions how the triage is very important to the patient who are sick, like this pandemic COVID-19. As we don't have any answer from audience on my question, please, when you are in the room after you donning, so you should have all patients with the masks, and you limit a point of entry because you know that is a very risk area. But also you must have the post of your alert for entrance points, and then you do assign dedicated staff for the triage for the critical patient, and you orient the patient in different room according to their critical condition they are in. So this, we have what we call green zone and red zone. We will see later in the breakdown sessions. So before you have your COVID-19 patient being triaged, there's what we call screening a patient from the community to know who to isolate to come to your treatment center where you do triage and you do doffing, or you do donning and doffing. So do we need to screen this patient we had in a previous discussion as a case of 57 years old who had the chills and cough and then the weakness. Do we need to do screening of these patients? And how do we do? Thanks to Pauline. Pauline is saying that you have to check danger signs or symptoms. So from her answer to the audience, it comes again the second questions. What are the common presenting symptoms or other symptoms you have to look for, Pauline or other members? For Diane, you have coughing. What else? Chest pain, loss of smell. So we'll be discussing in details more in breakdown session. So our patient who came in, as you know, in the history taking, he had the oxygen saturation of 89. Dr. Honorin, can you take over? So these are common symptoms we discussed. I mean, we had here, but we will be having in details in the breakout sessions. Our patient who come in after having 89% of oxygen saturation in the blood. What is it, Dr. Honorin?
We keep our cases. Now we go to the case update. Slide 13. Okay. Our patient denied fever, shortness of breath at rest, headache, loss of taste, or loss of smell. He is talking in full sentences, but states he becomes short of breathing with moving and eating. He has been less active and is mostly staying in bed or on the couch. For the first vital signs, they found to be with a heart rate of 95 beats per minute, a blood pressure of 95/52 millimeters of mercury, a respiratory rate of 24 cycles per minute, saturation of 89% with a temperature of 97.5 degrees Celsius. We go to the audience. What is the hypoxemia? What is hypoxia? And then you can give me difference in 1 minute, and then we continue. From the audience, what is hypoxemia? What is hypoxia? And what is the difference? Thanks, Mbabazi. Thanks, Hope. Thanks, Stephanie. Okay, we can go to the next slide, then we can see what is the difference. Hypoxemia is a decrease in arterial blood pressure of oxygen, and the arterial oxygen partial pressure is mostly less than 60 millimeters of mercury, and the saturation is less than 90. And remember how was our patient? The saturation was 89%. And hypoxemia is defined as reduced level of tissue oxygenation. Normally, we know oxygen is attached on hemoglobin in the blood and dissolved into plasma. So to detect the amount of oxygen in the blood and in the plasma, we have to use different tools. The best and accurate one is arterial blood gases, where you can find the arterial oxygen saturation and the arterial oxygen partial pressure. And the other one is the pulse oximetry. Next slide. For our patient, if we see he has a hypoxia based on the desaturation, what is the most common cause of hypoxemia? From the audience, I want to hear from you the different cause of hypoxemia. What are the different causes of hypoxemia? Thank you, Claudine. Thank you, Brice. Thank you, thank you. Okay, thank you. We will go deep about the cause of hypoxemia in the group session. Now, Alana can share the video from RC that's showing the cause of hypoxemia.
It is also important for healthcare providers. In addition to diagnosing hypoxemia, it is also important for healthcare providers to recognize the common causes of hypoxemia in neonates, children, and adults. Hypoxemia is defined by low levels of oxygen in the blood and is detected using arterial blood gas analysis or pulse oximetry. Pulse oximetry is more widely available, but arterial blood gas analysis is more accurate when available. The exact level of oxygen saturation that defines hypoxemia is not clearly defined, as the level at which tissue hypoxia occurs is not known. However, most clinicians agree that an SpO2 less than 90% by pulse oximetry qualifies as hypoxemia. A hypoxemia diagnosis can be made using arterial blood gas analysis, but if ABGs are not available, a pulse oximetry unit can also be used. In the instance where neither tool is available, bedside providers must use clinical signs to guide administration and titration of oxygen therapies. Common causes of hypoxemia in neonates include, but are not limited to, birth asphyxia, respiratory distress syndrome, pneumonia, sepsis, congenital heart disease, meconium aspiration syndrome, and apnea. Common causes of hypoxemia in children include, but are not limited to, acute lower respiratory infections such as pneumonia or bronchiolitis, asthma, meningitis, sepsis, congenital heart disease, perioperative complications, malaria, and trauma. Finally, common causes of hypoxemia in adults include, but are not limited to, chronic obstructive pulmonary disease, asthma, pneumonia, sepsis, trauma, congestive heart failure, pulmonary embolus, and perioperative complications.
Thank you. The next slide will be for Jean-Paul Mvukier. Jean-Paul Mvukier.
Good afternoon.
Good afternoon.
After having this patient with hypoxemia, how will you treat hypoxemia? I'm asking the audience, given this patient who is saturating 89%, with given vitals on the screen of monitors. For the audience, how are you going to treat this hypoxemia? Anyone with an answer? Yes, you can text, you can use the chat and tell us. This patient is the, yes, Claudine, you put on oxygen, yes. Absolutely, you are mentioning that this patient will need oxygenotherapy. Yes, oxygen and normosaline, yes. Change the position and the oxygen therapy, yes. Oxygenotherapy. All of us, you are mentioning oxygenotherapy. Let us get, yes, A, B, C. I like the answer. Let us get the next slide. Next slide. Oxygenotherapy, yes. So all of us, all of you, you've mentioned that this patient will need an oxygenotherapy. How? By which device? How will you choose each device according to what? What are the type of oxygen device do you have in your hospital? How do you choose it? Which one? Ventilator machine, it's an option. What else? What is other device that you are going to use? Can you use a simple facial mask, nasal cannula? Yes. What else? Facial mask with reservoir? Yes. What else? What else? What else? So you mentioned nasal cannula, you mentioned simple facial mask, you mentioned facial mask with reservoir. Yes. Invasive and non-invasive CPAP. Yes. Yes. How do you choose? How do you choose to use a nasal cannula or simple facial mask? How do you choose? What are the criteria you base on? By choosing, you have nasal cannula, you have simple facial mask, you have facial mask with reservoir. What is the guidance? Correlate with the signs of distress assessment? Yes. What else? How about FiO2? Yes, level of hypoxemia. You base on the level of hypoxemia. Also, you need, yes, the ABG. You should also base on the FiO2 that these devices are delivering, because they are not delivering the same FiO2. Also, you will consider the flow, the flow of oxygen. So we are going to see this in details in a breakout session, but this in summary, you base oral, you mention with FiO2 again, and the flow, and also the degree of hypoxemia. Let us get the next slide. Next slide. All of us, we know that in our setting, in our hospitals, do you use, let's take like, here there is some examples of nasal cannula, simple facial mask with reservoir. In our setting, maybe before I leave this slide, even if we are going back in the breakout session, but the nasal cannula, knowing that the flow is 1 to 6 liters per minute. And when you are giving above that flow, you know that you are not helping at all the patient. The FiO2 nasal cannula is able to deliver is ranging between 25 to 40%. And this one is reserved for someone who is not very hypoxic. With mild hypoxemia. The simple facial mask, where you can go 5 to 10 liters per minute of flow, also knowing that you are giving an FiO2 between 40 to 60. This one also you can use this on patients with mild, moderate hypoxemia. The other one is facial mask with reservoir, which can deliver from 10 to 15 liters per minute, and the FiO2 ranging 60 to 95% on room air. This is the strong one. You can use the last one for the patient who is very hypoxemic. Combining with the next slide, after using this facial mask, do we throw away this cannula or this nasal cannula or this facial mask, or there is a way of to be reused? How are you using it? What is the behavior in your hospital? Is it simple? Is it single use, or do you reuse? Tell us in your hospital how. Next slide. I'm asking it to the audience. The facial mask or nasal cannula you have in your hospital, in your institution, you reuse, okay? Reuse. Anyone? Single use? Reusable? Can it be reused? How do you clean it? Next slide. So the majority of participants are saying that these equipment are being reused. And how do you clean it? Anyone with an answer? How do you clean this material? Water, then Sidex, then normosaline. Yes. Anyone with different answer? Anyone with different answer? Next slide. So, yes, reusable, properly cleaned with normosaline and the sterilization, yes. We will come back again in a breakthrough station where we will see the cleaning, we'll go in details, but mainly we use this material, and we are going to see how properly clean this material. About the administration of oxygen, all of us say that this hypoxemic patient will need oxygenotherapy through different devices. Where comes oxygen in your hospital? What is the source of oxygen? Do you have enough oxygen in your hospital, or do you have some shortage of oxygen? I'm asking it. Walls and tank. Which tank? Tank of what? Mirror oxygen. Yes. What's the another answer? Again, we are going to discuss in details. Yes, thank you. Brice is mentioning concentrator, oxygen concentrator, oxygen cylinder. Yes. So we are going. The others they mention the mirror oxygen or piperine. The mirror oxygen, knowingly that is coming from a source, from oxygen, yes, cylinder and mirror. So we are going to discuss this in details, but you mentioned the most of the answer, the oxygen cylinder and mirror oxygen or piperine or oxygen concentrator, which is portable. So we'll discuss it later in the breakthrough session. Next slide. So we need.
Thank you very much, the whole team. The presentation has been very good. As we are preparing, we are being broken into 3 different stations. Some of the key learning, can you bring back that station? Bring back the slides as we are breaking the session. So some of the key topic we've reviewed are, we need to remember IPC in everything we are doing, infection prevention control, how to protect yourself, how to protect the patient. And also when you are cleaning all the devices, you are protecting your team and yourself. So we've learned about PPE, personal protective to the exposition. You should be well protected when you are saving others, you need to be saved yourself first. So you better be protected, that you protect yourself against the patient and you protect the patient. So we learn about the donning, the doffing, we learn how to screen patient for COVID-19 and do the triage. Hypoxemia, you've learned many of the patients are dying. They die, most of them, by hypoxemia. Some of them will die with from the disease, some of the disease, but mostly it's hypoxemia, which is caused by COVID. And so you need to diagnose the hypoxemia and to treat, to learn how to use the pulse oximeter. It's very important. And when to choose which flow of oxygen to give the patient and which source to use. So soon, when we go into the stations, I think it will be 10 minutes per station because we've discussed much during the presentation. So I advise Alana, as you are breaking the station, every station will take only 10 minutes. So we will rotate from one station to another one, to another one. After 3 rotations, we will come back again into the room for common discussion, for a wrap up, and that will be the end of the session. So we have 30 to 35 minutes to rotate into 3 stations, then come back.
Yes, and before I break everyone out into the rooms, I just want to explain it a little bit. So in a moment, you'll see a box on your screen that says you're being moved to a breakout room. Each room will have a chair that will facilitate a discussion, and then we'll rotate 3 times. So you'll have 3 different breakout sessions. And then once in the breakout room, if you have any thoughts that you want to share with the main class, keep that in mind because we'll give you the option to bring that back to the main group once we come back out of the breakout room. So keep that in mind. When we are in the breakout rooms, there are a couple of controls that I wanted to let you know about. If you're having any technical issues, there's a button that says ask for help on your screen at the top left. Click that and someone will join to help. You will be able to speak in the breakout rooms. You'll be able to unmute yourself. So please do that. And we encourage you to turn on your video as well. But of course, if your internet connection is unstable, turning your video off might actually help. So it just depends. If you want to use the chat box and you're not comfortable speaking out loud, you can click on more and then chat to share your thoughts in text. And then finally, when there's 1 minute left, we will send a warning out so that you can wrap up your conversation and get ready to rejoin the main class. So just in a moment, you'll see yourselves breaking out into the breakout rooms. Dr. Banguti, was there anything else you wanted to say before I let everyone go?
No, we can go. We can let them go.
Okay.
Thank you very much. Where we've discussed few points, which I would like to summarize and to wrap up. And you are allowed to ask question using your chat as we are wrapping up. Question where you feel like you didn't get enough information and you would like us either to clarify or to take the point for the next discussion. So today it was about consideration for triage. It is, we need to do triage to get the right patient in the right condition to whom we'll give the right dose of oxygen, which we take from the right source. Meaning what? We don't want to kill a mosquito using a gun, taking like a flow of 20 liters per minute to treat just a mild hypoxia. And imagine if you are using it to a patient without isolation and is already COVID positive, so you are infecting yourself or you are infecting him, you are giving him a wrong dose of oxygen, you are giving too much, you are making loss to the hospital. So you can have a good intention to treat, but not using the right dose to the right patient. So that's why we need to do a proper triage. Triage to isolate the suspect patient, triage to protect yourself from contamination, triage to pick up the very sick patient who is in severe hypoxia, triage to pick up a right tool, a right device. If the patient is severely hypoxic, you need high flow oxygen to increase the FiO2, the inspired fraction of oxygen. If your patient is severely hypoxic, maybe he needs 70% of oxygen. So when you are using a simple facial mask, even if you put the flow at 20, you will not reach the 70% of oxygen. So you have a good intention, but you are not treating. You can say, I gave him oxygen, but it's less. It's not the right. So you need to understand which device to use. And then when you finish to use it, you need to know how to clean it. If you are in this hospital where you don't have enough mean, sometimes we get products from Europe or America where it says single use, yes. But if we can't get enough mean to buy for each and every one, we need to agree as an hospital with our managers and IPC team how to clean and disinfect our fish, decontaminate our tool, to reuse them if allowed, if appropriate. I don't say we should reuse everything. You need to have the senior management of the hospital involved in your decontamination procedure so you don't put at risk your patients. Then also you can take care of your patient. So I know there is some gap, some lack of good information, but as you can see, we have 12 sessions where all information will be coming back. Like the next session will be on hypoxemia and hypoxia, just on that, and how to use the pulse oximeter. We will go in depth how to use the pulse oximeter. How do you interpret the sound you hear? All those will be discussed in the next session. Then after that, the third session will be about escalating care. When do we come from a nasoprom to the mask, to the reservoir, and to the high flow, up to intubation and ventilation? That will be the third session. Then the fourth session will be fundamental of critical care. And remember, we promise you that if someone follow the full session up to April, he can have a level 1 certificate from our institution, and will have his first batch of CPD points. Then the other second level will be another level 2 certificate. So we want you to be really, as you started, attend the second, the third, and the fourth to get the level 1 certificate. So this is a call for you to be present for the next session. I can see in the chat there is no more question. It means we have to congratulate Liberata, who, despite the challenge of the IT, but she managed to catch up and did a great job. Liberata is a nurse at the University of Rwanda. She's the track leader for critical care, and we are happy with the job. We have to congratulate Francois, who is a physician leader at the new Nyarugenge hospital where the COVID center has been located. He's the one taking care of the COVID patients. That's why we invited his expertise to come with us. We congratulate Jean-Paul, who is a lecturer at the University of Rwanda, working in Butare. And we also congratulate Alana. Thank you very much, Alana, for really helping us in IT. And all the participants, I know some of you get some challenges to join us. We say next time we are all learning, and we have to move from the old era to the new era with IT. So that is the way to go. Some classes will be given like this. The more you get exposed, the more you know, and the more you will no longer complain about how to get your session, how to be taught, how to learn. E-learning is the way to go. So from this done, we can say thank you very much, the whole team. We are finishing our session with 80 participants. Thank you very much. So the floor is yours, Alana, if you have something to say before closing.
Yes, thank you, Dr. Banguti. And yeah, today, as echoing what you said, it's a learning process. So if you had technological issues, so if you had trouble hearing the presentation, if you had trouble joining, if you had trouble in the breakout rooms, just email or WhatsApp me if you're on the group. And what I've been doing with other participants is setting up private messaging or even a test call to see if we can resolve those issues, and we'll be able to do that before session 2, because sometimes there are quick little tips and tricks to set up your Zoom settings so that you can resolve that. So definitely reach out to me, and I'll include my email in the follow-up. But yeah, just to wrap up, all of the materials discussed today are available on the Learning Resource Center. So the Learning Resource Center is an online platform that has all of the course modules, quizzes, case exercises, and videos. So we'll be circulating a link to register for that soon after the session, along with the recording for today. So if you did lose connection for a little bit, not to worry, because we will circulate that for you. And then if you aren't already on our WhatsApp group, please do join. The link was in the invite, and I'll include it again in the follow-up. But if you have your phone with you right now, you can also scan the QR code that's on the screen here. But otherwise, thank you so much for joining today. We have 11 more sessions to go, and we hope that you will join and stay with us for all of them. And so yes, thank you so much for joining, and we hope to see you next time.
Bye.
Bye, everyone.
Thank you.